I have the same disclosures as yesterday, nothing new. Our approach in the neonatal unit now, as NAVA has come into play more, is to start with babies when they come out of the delivery room, give them surfactant, load them with caffeine, and put them on NAVA. The question then becomes, how early? Well, we can either interpret it as how early as far as gestational age goes, or how early as far as chronologic age, 1 hour of age, 6 hours of age, 5 days of age. So I'm going to address that just a little bit as we go through. Our approach then is to start to wean the NAVA level as aggressively as we can down to a level of 1, and if the FiO2 is low, go ahead and extubate, start again in a non-invasive NAVA level of 2, and then do the same process of weaning as aggressively as we can to a NAVA level of 1, and then coming off ventilation completely to CPAP. If the baby starts off as extubated, we'll start them on non-invasive ventilation if they need it, if they're failing CPAP. We start at a level of 2, we wean as rapidly as we can to a level of 1, and then we go back to CPAP. As you can see, I don't put any timelines on the chart, on the slide here. I'm not saying wean over 12 hours, over 24 hours. Some of these babies move really fast, and others, we get stuck in the non-invasive phase for 3 to 4 weeks. So it's very variable, but this is our general approach. So, again, how early can we start? When I was in training, we used to have these tiny little preemies come into our unit, we'd intubate them, we'd give them surfactant, and this was just at the time that surfactant was becoming very popular and that we were showing how well it works. They would rapidly wean to room air, and they would look fantastic on the ventilator. And we'd say to the family, your baby looks great. He's on low pressures, he's on low oxygen, he looks fantastic, but don't get excited. This is called the honeymoon phase. Over the next few days, he's going to get worse and worse, and then we're going to get into that chronic phase, and it's going to take weeks, if not months, for him to actually recover past that. And we always expected that get worse before they're going to get better. The question now is, do we need to do that? Do we need to tell this to parents? Why are these babies doing it? How much of it is it the preemie, and how much of it is us that we are hurting these babies? So, about 2 weeks ago when I was planning, going through this talk, this baby showed up. A 23-weeker, 540 grams. This is about as bad as we see. Mom was a nurse in our hospital, actually, and she had good posture syndrome. As a neonatologist, I had no recollection what this was. But for the adult docs, you know it involves the kidney and the lungs and basement membranes and stuff. But Mom hadn't been feeling well for a few months, and she had a feeling she was pregnant. But every time she took the home pregnancy test, it came back negative. So she kept going to her good postures doctor, to the nephrologist, and telling him, maybe I'm pregnant, and he'd say, well, what's the test show? Well, it's negative. And anyway, at 23 weeks, she starts abrupting, and she delivers this baby that she's not pregnant with. And it turns out, for reasons, again, I don't understand, that good postures can give you a false negative pregnancy test. So if somebody had actually listened to their patient and sent it for a blood pregnancy test, they would have known she was pregnant. So not only is it a 23-weeker, but it's a 23-weeker born to a mom that had no prenatal care, had no prenatal steroids, had no prenatal magnesium, had nothing that we know can help and protect the babies. So this is about as bad as we can see. So obviously, I had to put the baby on NAVA. So first we put the catheter in. Now, we have challenges in the neonatal unit that you guys do not have in the adult and pediatric world. Our babies are tiny. At 540 grams, we have a NAVA catheter in, and ignoring the blue signal over here, just look at our EKG progression. What you like to see is from large P waves to absent P waves, large QRS complexes to absent. If you look at the top part of the screen, it looks like the catheter is in too far. I mean, it's not in far enough and maybe needs to be pushed in just a little bit. If you look at the bottom part, it looks like the catheter might be in too far. And actually, it's because the baby's esophagus is so tiny that we can really only use 3 electrodes to detect catheter placement. So in these tiny, tiny early babies, we needed to adjust the way that we look at our catheter position. So as long as we're seeing some sort of progression here and we're seeing a signal, we find that these babies are able to ventilate well. The second problem we have with our tiny babies is they have apnea. Now, apnea is not pathologic, it's physiologic. Normal 23-week fetuses breathe in utero, they have breathing movements, but are mostly apneic because they are on heart-lung bypass, which we call the placenta. So they don't need to breathe. So when they come out and now they're sitting in our NICU on a ventilator, they don't suddenly know what to do. They do the same fetal patterns of sometimes they breathe and sometimes they don't. And if you look at the baby's 12-hour tracing from about 8 to 20 hours of age, you can see at the EDI signal over here that we have some very low areas and even some absent areas interspersed with areas of really good regular respiration. And if you look at our respiratory rates over here, you can see that at these points of time, the spontaneous breathing is wonderful, and other times, the baby's in backup almost all the time. If you look at our pressure tracing, we use the trend screens a lot. If I looked at this pressure tracing, I could look at the pressure and say this baby's been in backup or in NAVA pressure support a lot of the time. Because when you're in NAVA pressure support or backup, your pressures are flat. Every single pressure is the same. But when you're in NAVA, breath to breath, your pressure is very variable. And you can see that every time the baby went into NAVA, the baby needed slightly lower pressures than we were ventilating with our backup ventilation. So our big barrier is our nurses and our respiratory therapists to come to me and say, why do we have this baby in NAVA? Because every time we go into the room and we look at the baby's in backup. For the neonatologists who use NAVA in the NICU, is this a challenge that you have? That everybody gets very upset when the baby's in backup. And I say, what do you want? Well, we need this baby in conventional ventilation because there's no point in having the baby in NAVA if the baby's in backup all the time. In our NICU, our go-to choice is SIMV pressure control with pressure support. So if we take a baby who's apneic, and indeed this baby is apneic, and we put him into SIMV pressure control with pressure support, an apneic baby, still apneic, is going to have a tracing like this. And I say to the nurse, so what have we achieved? And as you can see, these are identical. The difference is that when this baby's respiratory center fires up again and starts to breathe, the baby will be able to breathe synchronously with NAVA, as opposed to when this baby fires up and starts to breathe, the baby's going to breathe partially synchronously with SIMV. So we'll talk about in a moment if that's good or bad. When we are on conventional ventilation, which is the first part over here, SIMV with pressure control, every one of our pressures are the same. And if you look at the trends, our switches to backup and our backup don't exist. But the concept still exists. On conventional ventilation, on SIMV, you're going to get a flow-triggered pressure support breath. You get a flow-triggered pressure control breath, depending on the timing of when these happen. And then, if there's no respiration at all, you get a mandatory pressure control breath that falls in the correct timing interval. So you can either be in assisted ventilation, or you can be in mandatory ventilation. And patients go back and forth between mandatory breaths and assist breaths all the time. But the ventilator doesn't tell you, I'm breathing with the patient, I'm breathing for the patient. It just does its thing. Once you get into NAVA, the ventilator now communicates better with you. It says, I'm in NAVA backup. And it tells you as it goes back and forth, and it records it all. But if you look at our respiratory rate over here, the light green being spontaneous, the dark over here being total. The black area that you see is the area of apnea, where the baby has no spontaneous respiration, and the difference between the green, and that green is then the backup ventilation. So on conventional ventilation, this baby was in backup a lot. Once we switched over to NAVA, even though the nurses came to me to complain that this point he was in backup, here he was in backup, all the black areas he was in backup. And they came to me and said, this baby's always in backup. But only when you pull up the screen, you can see that the problem actually got a lot better than a lot worse. So a lot of it becomes education and understanding what you're looking at. So some of the stuff I showed yesterday, the NAVA, and for the discussions we've had today, I'm pretty comfortable that NAVA works in our babies. It does what Jennifer and Krista and the rest of the team designed it to do. It allows babies to control their ventilation. So what? The real question is, does it make a difference? Is this just another toy for us to play with, or is this going to make an impact? What we did was we are part of the Vermont-Oxford network, which we contribute about 135 babies, less than 1,500 grams a year, to a network of 950 plus hospitals from all around the world, and they usually get about 36,000 babies a year into the database. So our contribution is very tiny, but at least our comparison base is very, very big. And we compared what I'm going to show you today to the entire VON network, which is all level 2, well, mostly 2 to 3 NICUs. In our NICU, we moved into a new unit in 2008, which is always just nice to know because that sometimes can change outcomes. In 2008, we also got NAVA. It was a busy year. And in 2010, non-invasive NAVA arrived. Once I started pulling this data out and reviewing it, I found some amazing things. Back in 2007, the solid line is going to be our data. The dotted line is the Vermont-Oxford 50th percentile data. In 2007, we were intubating over 80% of our babies, less than 1,500 grams, got an endotracheal tube placed at some time. Even if it was for 10 minutes to get surfactant, we put an endotracheal tube in that. I was horrified to see how often we intubated our babies. As time has gone on, our practice has changed significantly. Now less than half our babies see an endotracheal tube, and the majority of these are the 23 to 25-week infants that we are intubating. Well, if we had to take that group out, our intubation of 26 weeks and above is actually very, very small. At the same time, our use of non-invasive ventilation has changed. We used to use a little bit in the first few years, but once NIV-NAVA arrived, bit of a learning curve, and then that's really taken off, and we've gone up 2 to 3-fold. And since the support and other trials have come out showing that CPAP may not necessarily be better than invasive ventilation, it showed that trying CPAP first was certainly no worse. So now all our babies, or many, many of our babies, except for the micro-preemies, get a trial of CPAP before we decide if they need to be intubated. So our practice has definitely undergone some changes over the last 6 to 7 years. In the next few slides, the yellow line now is the 50th percentile from VON, and the green line is the 75th percentile from VON. And for all these outcomes, except the last one I'm going to show you, the lower you are, the better it is. As you can see, amongst the 950 NICUs who contribute to VON, as hard as we've tried to impact chronic lung disease, as a network, we haven't really done much. Steroids, vitamin A, volume guarantee, high-frequency ventilation, all those things thrown in have not impacted chronic lung disease very much at all. Very frustrating to us as a network. At our hospital, we have seen a difference. We started about the 50th percentile at a chronic lung disease rate of about 23, 24%, and came down to 2013, we were down to 8% chronic lung disease, a huge drop in our chronic lung disease. Our median length of stay in the hospital has changed too. Another big area, try and get these babies home sooner, get them to their families again. The network, not much of a difference. Our hospital has seen a significant drop as well from the low 60s down towards about 50 days. So we are getting our babies home sooner as well. Now, one of the outcomes that we can look at as well is death and morbidity. I need to include this because if I let my babies die, they don't have chronic lung disease, and they go home pretty quick. So if you have a very high mortality rate, that can influence your other numbers. So the combined statistic then becomes very important. And again, as a network, we're improving a little bit, but not a huge amount. And we have seen a nice change from being at about the 50th percentile to now well below the 75th percentile of the collaborative, or well above the 75th, I should say. And then finally, how many of our babies are leaving the NICU without any long-term morbidities that we can measure at the time of them going home? So interventricular hemorrhage, retinopathy of prematurity, bronchopulmonary dysplasia, the major criteria we look at. And again, as a network, we are seeing a slow, steady increase over time, but we have seen quite a reasonably good impact of our outcomes over time as well. So, to answer the question now, it works, does it make a difference? Well, it's a definite maybe. I really don't feel comfortable standing up here, and I don't want you to interpret what I'm saying is that all the stuff I showed you is because of NAVA. I would love to be able to, but it really is very complex why these babies improve outcomes like this. And I think it's due to multiple factors in our unit, of which NAVA and NIV-NAVA certainly play a role. I think NAVA has given us a lot of confidence to trust our babies that they breathe spontaneously, and also NIV-NAVA has given us a lot of confidence to pull those endotracheal tubes out because we have something good to offer them now that we can sustain them off the ventilator. However, we are going to need large multi-center trials to answer the questions that we need to know. Will it prevent intubation? Will it decrease our time on the ventilators? Will it decrease the incidence of chronic lung disease? And then, especially after the talk we heard before this, will that improve our long-term outcomes? Yesterday, I showed you some data on the pressure distribution on non-invasive ventilation. This morning, we heard in the adult world about driving pressures and how high pressures can be dangerous to patients' pulmonary outcomes. And then we heard about volume and how the different trials have shown that low volume ventilation may be better. In the neonatal world, we have a similar approach to try and prevent barotrauma and try and prevent volutrauma. And our goal really is, in the adult world, you'd like that 6 mLs per kilo. In neonates, it's more about 4 mLs per kilo when we're using volume guarantee to try and stay in that range. And that's kind of our best guess. But what do the babies really look for when we have a chance to let them control it? So here we can see that 24 babies, small, early, and looking at a lot of breaths again, 750,000 breaths. For volume, for pressure, and a lot for volume. I've got 2 more slides. I promise not to hold everyone up. So here we can see our pressure distribution. Again, about 10% having high breaths, but as we saw yesterday, the majority of the pressures are very low. The babies can ventilate themselves very efficiently with very low pressures. And most importantly, looking at tidal volume. I'm starting at 0 to 1 mLs per kilo. It's all been normalized to body weight, all the way up to 9 to 10 mLs per kilo. And you can see that even though we have 5% above 7 mLs per kilo, the majority of the breaths, 26 plus 24 is 50, 66, 78% of the breaths are less than 4 mLs per kilo. So by allowing the babies to take these recruiting options, we are allowing them to then ventilate the majority of their breaths with these very tiny tidal volumes. And finally, I want to stop where I started. I introduced you to that 23-weeker at 12 hours of age, and because I knew I was going to do this talk, I went to go and speak to Mom, and she gave me permission to come in and video. So here's our baby.
Every breath you take,
oh no.
every move you make, every bond you break, every step you take, I'll be watching you. Every single day, every word you say, every game you play, every night you stay, I'll be watching you. Oh, can't you see, you belong to me? How my poor heart aches with every step you take, every move you make, every vow you break, every smile you fake, every claim you stake, I'll be watching you.
Okay, thank you very much.